And we're going to record this session so we can save this presentation and put it on our website for those that choose to view it later at a later time, and know that it's a part of our wonderful library of excellent speakers, and the Temple Israel is proud to have such a program. So I want to welcome those that have joined us, and those will be more joining us along the way as part of Temple Israel's series of presentations on a variety of topics that are very poignant and timely, and none more timely than Heather Friedman-Cohen's position tonight as a doctor working at Valley Hospital and talking in the emergency room and talking about COVID. And then when she finishes her presentation, her husband Randy will be talking more about lifestyle of how your lifestyle affects your health, and we all know that is true. And what I would ask everyone to mute their computer or tablet at this time, and if you have any questions, please put them in chat for the moment. Heather will give you time to ask questions at the end, but we want to give her a chance to present fully, and then when we'll break before Randy comes on, and we'll do the same thing, so you'll have a chance for Q&A for both people. So welcome this evening, and we're delighted to have you pre-high holidays. Heather, and why don't you introduce yourself and say hello, and give everyone an understanding of what you're going to be talking about, and you can begin your presentation.
All right, so hi everybody. My name is Heather Friedman-Cohen. As I said before, I grew up in the Temple Israel community, and am now a pediatric emergency physician at Valley Hospital. Been working there about a little over 8 years now. So we recently moved back to the area shortly before that, and have been working in this community for about 8 years, and doing this for over 15 years now, since finishing my residency. So the topic, is about COVID-19 infection in the pediatric population. I actually wrote the presentation a week ago before going on a little holiday with the family. Much has evolved since 1 week ago with the emergence of the Delta variant. So some numbers and data is still emerging. And so forgive me for that if things are a little off there. But we hear much about COVID-19 in the adult community for the past year and a half, but you don't really hear a whole lot about the pediatric population and how it really affects them, and thought that it would be helpful to discuss how kids are affected, because they are affected. And, it's important to know how the disease looks in the pediatric population. So some epidemiology. So as of August 2021, we have 12.7% of all cases in the US have been in children. And 16% of those cases tend to be asymptomatic, meaning they show no signs or symptom of illness. So they can be walking around, looking perfectly well, but still carry the illness and still therefore be contagious. What we have seen as far as trends was that the incidence increased with age. And that is still true even with the emergence of vaccines in the older children. We still see this to be true. Although now, of course, those numbers in the under 12 population have been driving upwards because they just don't have the benefit of being able to receive a vaccine as of yet. So what we were seeing, is, the under 4 were about 70% of the population affected, 25% in that 5 to 10 year range, 18% in that 11 to 13 year range, and then 38% in the over 14-year-old. And, that is for a variety of reasons, some of which is behavioral, I would say that probably greatly contributes to that. In addition to, some of the factors that seem to make it a little easier to spread in the older kids and the adults, or at least that's what was initially thought. As far as people who would be hospitalized, we were seeing about 8 in 100,000 were under 18 years of age. And that's 8%, okay? And then of that 8%, 24% were under 2 years of age. So the very young were the ones that got hospitalized more so, than the older children, the ethnic distribution that we tended to see more, the non-Hispanic Blacks and the Hispanics, were affected 10% and 16% per 100,000 respectively. And the biggest contributing factor, which much like the adult population, was chronic lung disease. Obesity, then followed by chronic lung disease. And obesity, in the adult population as well, still remains the biggest, contributing factor to risk factors. Interestingly, these trends, maybe not the ethnic distribution in our community, but the obesity trends we were seeing very early on, and we took notice very early in the early months of winter last year. So risk of death, because children do die from COVID, even though by far and away, far less commonly than you would see in the adult population. You only get 0.17 per 100,000 deaths, in the pediatric population. So while you'll see children getting it and getting hospitalized with it, thankfully most of them do, ultimately recover, to some degrees, and thankfully are not passing from the illness. That being said, your risk of death, increases in the older teen years, in males and also in minorities. Okay, so the risks of exposure, by far and away, what we were seeing and what we still see is the risk of exposure in the pediatric community comes from household contacts, meaning, adults that they either are in the home or, perhaps that they are frequently exposed to, tend to be the biggest risk of exposure in the pediatric population. So that includes visitors to the home, gatherings with an infected person who is from outside of the home or in an outside setting, or an inconsistent mask usage in the schools. Now, with vaccinations being what they are, the other risks now would be unvaccinated adults, or unvaccinated teens, increasing the risk of exposure in that under 12 population, and really now driving that number up. So what I was telling Bob earlier is that last week I started seeing, things in the journals coming out saying that the increased incident from the Delta variant, because of its spread primarily through, unvaccinated persons, have driven the percentage up in the pediatric population like 15% from those numbers we were talking about. Now, they're still having data coming in, and they don't have all the hard data yet, but these are the trends that they're starting to see. And again, so risk of severe disease, obesity, number one, medical complications, children with genetic predispositions, neurologic conditions, metabolic disorders, so think diabetes and like, children with congenital heart disease, chronic lung disease really is number two, sickle cell disease, and those who are immune suppressed. So clinical manifestations, it tends to vary, between the different ages on, what their more presenting symptoms are. In the under 9 years, fever is almost 50%, you will see having fever at some point of the illness, followed by cough, headaches, sore throat, abdominal pain, vomiting, diarrhea, tend to be up there in the, 15% range. So you could see, just looking at this short list, pretty much any illness that you can think of, can be a presentation of COVID. And interestingly, the one that gets the most press, which is the loss of taste and smell, tends to be the smallest percentage of patients. As we go up in the years, however, in the 10 to 19-year age range, you see that loss of taste of smell coming up, more significantly, now reaching 10% of the population and starting to kind of approximate what you were seeing in the adult population. But the younger kids don't tend to get that as much. But again, fever, only 35% in this age group. So, that's a third, 2/3 don't have fever. So how we were used to be testing everybody, if you have a fever or what have you, many of those patients don't have fevers. So it's not the greatest screening tool, as we have come to learn. So complications that you see in the pediatric population, while less common than you would see in the adult population, you still will see it. Heart failure, arrhythmias, I apologize for my typo there. Myocarditis, which is heart inflammation, pericarditis, which is inflammation of the lining around the heart, cardiogenic, that's supposed to be shock, I apologize. Pulmonary embolism, which is a clot in the lungs, and related to clotting disorders that you see due to COVID infections. You can get myocardial infarctions or heart attacks, in the pediatric population. You can get inflammation of the brain, the encephalopathy, pancreatitis, stroke, again, due to clotting issues, Guillain-Barré, which is a paralysis issue related to, you can see in a variety of viral infections after the infection, but you see that also in COVID. And then, several other things, and then mental health issues, psychosis, being one. So we'll talk about some of the heart stuff more, the myocarditis and the pericarditis, when we talk about vaccinations, because, it's interesting. There's been much press about myocarditis related to vaccinations, particularly in the adolescent males. But you did see that with actual infection with COVID, and actually was one of the most common reasons, if not the most common reason, why children were admitted to hospital, especially early on. And that brings us to this topic, which is the multisystem inflammatory syndrome in children, or MIS-C. So, as an interesting aside, this variety of symptoms very closely resembles something that we would see very rarely in the pediatric community, called Kawasaki disease. As a matter of fact, in the beginning, it was thought to mimic it entirely. And, as an aside, I would say back when COVID first started, February, March of last year, we saw a cluster of patients, who were presenting with what we thought at the time was Kawasaki disease. Now we knew it was multisystem inflammatory syndrome. Just at Valley Hospital ER alone, a small community ER, within a month, we saw probably 4 cases. Each one was seen by a different doctor. You know, we didn't know that each other was seeing it at the time. But nonetheless, we did see it. And, you know, we came to discover that this is what we were seeing. And I could tell you that the numbers that I would see by far and away in the literature are vastly underreported, because we probably had about a dozen of these cases or more just in our small ER. You know, and I would imagine in ERs throughout the country, they were seeing this and sometimes didn't even know what they were seeing. So I think the reporting of this in the pediatric community is vastly underreported. Sorry. Oh, I thought someone had a question. So what this is, you know, the definition, you were seeing this in the under 21 age group specifically. You know, you would have fever for more than 24 hours and typically more than 5 days. You would have laboratory evidence of inflammation. These are just some of the different laboratory markers that we would look for and look for now when you arrive to the hospital. You would have more than one system involved. So heart, you know, kidney, respiratory, you know, blood, you know, gastrointestinal, you know, dermatologic, so rashes or neurologic symptoms with no other plausible causes. So you would kind of, you know, eliminate this Kawasaki syndrome, although truth be told, it would be very difficult sometimes to fully eliminate that. And then of course you would have to have, you know, either exposure or positive testing, you know, to COVID, you know, within the recent few weeks prior to symptom onset. So the way it would work is that you would, you know, have exposure, and then, you know, within days to weeks and up to as long as a month or so after exposure, you would present with this syndrome. So you could have a known COVID infection, you can be sick, you can appear to recover, and then, you know, several weeks later, start again with fever, and it's related to this. Okay, so again, the incidence is not well known, largely due to a really underreporting, you know. They think it's less than 1% of all children diagnosed with COVID, you know, but account for 64% of the patients who end up in the ICU. Out of all the deaths, you know, now granted those numbers were low, any pediatric death is one too many. And 1.8% of the deaths in the pediatric population is thought to be related to this. You know, again, you see it more, you know, in the minority population. So Blacks and Hispanics make up quite a large amount of it. But the Caucasian population, the Asian population as well, you're seeing it more predominant in boys. And again, obesity being your highest risk factor. So when patients present with this, more than 86% of them have 4 organ systems or more involved, you know, and tend to make up the hallmark of this multisystem inflammatory syndrome. And a lot go on to have, you know, heart dysfunction and heart shock, you know, which basically means that, you know, your body is not able to effectively circulate blood to the brain and vital organs because your heart is failing. And you get heart inflammation, which is the myocarditis. And then coronary artery dilatation, which is what you see in Kawasaki syndrome. You also see it here as well. And then kidney injury, in some patients, kidney failure. You see that in about 18% of the population. The treatment for it is very similar to patients who have Kawasaki disease. They get something called IVIG, which is an immune globulin. They get treated with steroids. There are certain biologics they have trialed, you know, with some success, and then low dose aspirin. And that is primarily to prevent, you know, clotting and such in patients who have coronary artery dilatation, where they can form aneurysms in their blood vessels supplying the heart itself and can form clots and therefore, damage to the heart itself. Now, this is probably the most interesting piece related to this multisystem inflammatory syndrome. So whereas you have heard of vaccines, causing some, heart inflammation in, like I said, adolescent males particularly, they have seen it, and we have seen it in the hospital. Those patients usually recover within days. No long-term effect, no long-term issues. They're largely minimal symptoms, and within a week they're better. These patients, they are on blood thinners and aspirin therapy, and they are not allowed to exercise or participate in their activities for a minimum of 3 to 6 months. And then, of course, depending on how well they do post, inflammation to the heart, perhaps longer than that. So if you think about children participating in soccer and baseball and softball and whatever things they do, they're, out of commission, for good half a year. And those are the lucky ones who recover. Okay, so there's also, we have in the adult population, you also have the long haulers in the pediatric population too, which make up about 4% of the population of patients who do develop symptoms. And it's highly variable in how many symptoms they have and how distressing those symptoms are. But it can be anywhere from just mild fatigue to headache, to some who have respiratory complications and are not able to really, re-engage in their usual sports and activities, which can be quite a bit of distress depending on, what the child's participation levels in sports and what have you are. Palpitations is a big one. We see that all the time in the emergency room. Patients will come in for weeks and months after complaining of just vague symptoms that they just can't shake, and really distressed by that. And then, of course, the loss of taste and smell, which can take several months to recover. Okay, so prevention, and this is, of course, our hot button topic, but vaccinations by far and away, is the, best defense that we have now against COVID. Masking, of course, has been, incredibly helpful, and it works, and, should widely be used and continue to be used now that we have our Delta variant here, with breakthrough infections and the like. But, as far as medications go, vaccines are the way to go. There's 3 different ones, as you know: Johnson & Johnson, Moderna, and Pfizer. And this just shows the effectiveness against, all variants. Although these numbers for Moderna and Pfizer have gone down a little now that, as I said, a week ago, these were the numbers that we were seeing. With the Delta variant, I think that's dropped by about 5–10% in both Moderna and Pfizer. And that's why they have now recommended getting booster doses. It really isn't a booster so much as a third dose. A booster implies you're getting a smaller dose of the same vaccine, but this is the same dose as your original 2 doses, given 8 months after your second dose. As it stands now, they don't recommend interchanging the vaccines, so you can't start out getting, a Moderna and then get your second dose of a Pfizer, or vice versa. The guidance regarding booster dose a week ago, they didn't come out with the guidance. Now we know they say 8 months after your second dose, all adults, who are eligible to get the vaccine should get that third dose, regardless of any pre-existing conditions. They've been recommending now for several weeks for the immune compromised to get it, as soon as possible. And they also recommend, that those who have had COVID infections, once they recover from their acute illness, should go ahead and receive the vaccine. Initially, when the vaccines came out, they recommended that if you had a prior COVID infection, you should wait 3 months before receiving the vaccine. Very soon after those recommendations were made, they did away with it and said you can get it as soon as you recovered from the illness. However, those who receive monoclonal antibodies during an illness, should still wait that 3-month period. Okay, so vaccine complications, that kind of touches upon what we were saying earlier, or I was mentioning earlier about the heart inflammation or the myocarditis and pericarditis. With Pfizer and Moderna, they were seeing this, and they were seeing it, in males specifically, the 12 to 29 after the second dose, 41 out of 1 million. So we're talking very, very small numbers of people, who would come in with, heart inflammation. And you could see it's a 10-fold increase between males to females. So females, the risk is even lower. These cases are mild and they resolve usually within a week. So the way they usually present to the hospital is they present with a little chest pain, and that's it. They're usually not in any distress. They're usually not limited much in any way as far as abilities to do their activities. And when you go ahead and you test them, what you'll see is a high rise in their cardiac enzymes, but their EKGs, their echocardiograms, all of that are normal. And they usually go down just as quickly as they go up. So within a week, the numbers go back down to normal and they're fine. The other thing that we have seen, is Guillain-Barré. They saw that more with the Johnson & Johnson vaccine, but again, these numbers are very small, 100 out of 12.5 million, which is negligible, in the vaccine world. Usually 2 weeks after getting the shots and usually in the older adults. Okay, so thrombosis and thrombocytopenia. So thrombosis means, ability to form clot more, but you have your platelets being low. Platelets are the blood cells that form clots. And so they were seeing this very unusual phenomenon, particularly with the Johnson & Johnson vaccine. They believe it was due to an autoimmune reaction that was triggered. And this one affected more females and usually older females. So they would come in with headache. That was the biggest complaint. And this was what it did. It caused a cerebral venous sinus clot, and it affected mesenteric vessels as well. And that was seen usually 1 to 2 weeks after vaccination. But again, the numbers were so small, they did not, I think it was just several days to several weeks that they actually halted distribution of the vaccine. And then they recommended that, the numbers are small and not showing enough evidence to hold off on the vaccinations, and the benefits outweighed the risk, and they resumed administering it. And I think that's it. Yeah, that's it.
Okay.
So-
I have one question for you in chat
Yeah.
that I'm sure you can address. Question was,
I can see it. That's the question.
is it safe for young children who are unvaccinated, whoops, I lost it there, to return to school full-time even with masks and distancing?
I think that, masks and distancing has always been shown to be very effective tools. And one of the reasons that we did not see, a huge outbreaks in the schools, which we had anticipated originally, was because, children, particularly the younger children, were very good with masking and tend to be the more compliant of the age groups. Your middle schoolers and high schoolers were less compliant because they would gather with each other mask-free after school and in their after school activities, whereas the younger children, who are the ones now really affected by the lack of vaccinations at this point, were the most compliant, and you really didn't get huge widespread outbreaks, So, I believe that it should, still serve its purpose, and masking and social distancing and hand washing, like all other, infectious disease, is by far and away going to be, a very useful tool, and continue to be a useful tool in those breakthrough infections with the Delta variant, even amongst those who are vaccinated. But until the younger groups have the ability to get vaccinated, that should still serve us well, as long as the schools enforce it. My only caveat, and this is my own, question, is now that we are introducing, full day school and mealtime to the equation, we did not have really any data regarding that over this last year, because most children were not in school for a full day, or at least certainly not locally. And so that will be interesting to see what, if any, impact that has. Hopefully it won't have much.
Okay, and as you were saying in some of the other data about underreporting, is that also the effect for side effects of vaccine? You think that it's underreported, or just not sure?
I think that, probably the heart inflammation, how many patients who experience body aches or just generalized, discomfort, if you were to go and draw blood measurements to see if their heart enzymes were a little bit elevated, it's possible, that there were many patients who experienced that were never picked up. But as I said before, those numbers decreased as quickly as they increased, and it had zero impact on them as far as, heart functionality and long-term outcomes, regarding heart function, that even if those cases were missed, I don't know that it would alter or have any impact on the recommendations, because the cases that we did know that happened regarding heart dysfunction related to the virus itself were far greater.
All right, and Debbie had a question. Can you describe psychotic symptoms in children?
Well, that's highly variable too. Also depended on, age. Psychosis generally, tends to be a psychiatric term, that hearing voices, that aren't there, seeing things that aren't there, odd behaviors. That is what psychosis is. In children of different age groups, it can look different. So that's the best I could probably describe that. That okay. That is not something that I've seen related to vaccination, or even so much illness per se. Depression by far and away was a greater symptom that we saw related to illness. And then, related also to just, the impacts of just, the new situations that we have found ourselves in with all this social distancing and all of that, had its own impacts on mental health, which is a talk for a different day, but.
Okay.
Yeah.
And does Delta appear to be as infectious in children as it is in adults? Some adult studies indicate Delta is twice as infectious as Alpha was.
Yes. The short answer is yes. It is more infectious.
All right. Are you seeing a rise in RSV at Valley during COVID?
So the interesting thing, that we saw in our pediatric population, a lot of pediatrics is infectious disease. We thought we would see massive rises in all infectious disease. But the interesting thing is that when you wash your hands and you wear a mask, not only do you stop COVID, but you stopped a lot of other things. And
Wow.
we had a huge, decrease in our numbers of all infectious disease over the year. RSV, flu, I think, nationally, I think they reported like 2,000 flu cases nationally last year
Mm-hmm.
because of all the masking and social distancing that was
All
done.
right, so there's a
Now,
good side.
that's the good side. The bad side, well, I don't know bad side, but just the reality is that now that, masking is less and social distancing is less, we are seeing again a big rise in our just general infectious disease, um, common players. And RSV has been rearing its ugly head much earlier than we expected to. So this summer we have seen, a big uptick much earlier in the season than we would expect to see it in the pediatric population.
All right, for the historians, are there any data from the 1918 Spanish flu on juvenile infection that can relate to COVID?
That I'll be honest, I don't know,
Okay,
that answer. So I would
that's fair.
have to look, and see.
So I had a quick question myself, and then
Yep.
I'll open it up to anybody else who wants to ask one more. It seems from your talk that there are a tremendous variety of body systems that can be affected by COVID-19 or the variant.
Yeah.
So this makes this diagnosis for you all over the place because you know what you're looking at. It may be something that followed a routine that was identified by certain markers, but with COVID-19, it could be any one of those markers. Is this making this more difficult for you to diagnose?
Yes. It was interesting. In the very beginning, in the pediatric population, we were instructed that if you tested positive for another virus that can explain symptoms, to not test for COVID, because they didn't believe at the time that kids could really get COVID or that it affected them negatively. Now we have come to learn that that is most definitely not the case. You can have multiple viruses at once, just like you could pre-COVID. And many of these viruses mimic other things. So, sometimes you can come with a sore throat and it's COVID, or, what looks like a stomach virus and it's COVID. And so unfortunately, what it yields is just a lot of testing, which I think will give us better data, going forward as far as the epidemiology of how prevalent it really is in the pediatric community or even the adult community. I think knowing those numbers is very important as far as prevention going forward.
Debbie has a question. She says, as a special ed teacher of young students with multiple disabilities, i.e. Down syndrome, what can I do to help the situation? Now with lunch, full classes, less distance, aides aren't vaccinated. Is there anything that she can do that we haven't talked about, or Debbie can always jump in and further the question?
Sorry,
No, go ahead.
So, I believe, with the fact that Pfizer got full FDA approval, they are able, or hopefully will be able to mandate it more, in those who are eligible to receive the vaccine. I know that the, teacher unions are beginning to mandate vaccinations. I don't know what it is for aides at this point, or if they will mandate it, based on, state or school districts. I don't know that answer yet, because that is, again, only just happened a week ago.
My understanding is it's October 18th.
Yes.
That they're going to require to have at least one vaccination, or they have to go for COVID testing.
Yes.
We have to go in now. That's a month and a half from now.
Yes. And it's interesting. It's the same, believe it or not, in healthcare. The hospital is mandating that, all healthcare employees or all employees of the hospital have to be vaccinated. It's hard to imagine that you would have access to something that was so good at preventing illness, and then you would not go and get it. And, that's just the unfortunate, way it is sometimes, that you have to allow people to make their own decisions and what have you, but as far as forcing people to get the vaccine right now, the best they can do is to have individual mandates depending on your, area of work. As far as what you can do in the classroom, masking is hard in the special ed community, for sure. Although they have done a better job than you would have thought they would have done, and better than some, older kids and adults who don't have special needs. They tend to be very, or I shouldn't say not all, that's a generalization. Many are very, good and do their best. But again, masking, hand washing, distancing. And as I said, with food in the mix, that's the big question mark. That's the truth of the matter. I don't know. I think that probably, and this would apply to other kids eating at your, desk, not having a lot of intermixing would be helpful in the, special ed community. How helpful is that? That I don't know. I think it just kind of depends on the specific population that you're dealing with and what their specific needs are. And it's probably variable, to be honest with you, depending on that.
All right, that's pretty terrific in a broad sense of what was going on. And anyone else have any questions they'd like to unmute and ask Heather before we switch to Randy? If not, then I want to say thank you to you for Heather providing a tremendous and a comprehensive view of the current situation. We hope that your patient population goes down and rather than up in the area of COVID, and you can go back to good old childhood diseases. And,
that's right.
It used to be in the old time,
That's right. I call them the OG viruses,
There you go. So we're hoping that that can revert and it doesn't go off the rails now that, as you said, the cafeteria is going to open up a whole new world, or we're all have to bring lunches from home. I don't know how that's going to go.
The good news is that I think with FDA approval, I think the, soon to follow will be the approval for those younger kids. So
okay, well,
that happens soon.
I hope that happens in the near future.
Okay, well,
fantastic.
Thank you. Okay, here's Randy.
Thanks so much, and we'll ask Randy to join us.
All righty.
All right, Randy, welcome. We'll get you to switch chairs.
Yes.
All right.
Now I have the hot seat.
You do, and you can screen share your presentation now.
Okay.
And as I asked for others, if people have questions, please put them in chat. And at the very end, we'll kind of open it up for anyone who has not been able to get a response to a question that you are talking about. More about our lifestyles and how that affects our health and our heart health. And I know people are interested in knowing more about that. So Randy, take it away.
Okay. Hopefully I can do this correctly here.
You have done it.
Okay, good. Everyone can hear me and see the slides?
Yes, we can.
Great. Well, thank you again for the invitation to speak. I always welcome the opportunity to, I guess, share what I love to do. I'm a general cardiologist and I do all the general cardiology things, but my passion, I guess, is prevention and wellness and how that can not only impact cardiovascular disease, but at the same time, impact overall health and wellness and longevity. So I appreciate the opportunity to share this today. So I thought I would start with a little quote that I'm sure we're all familiar with. Benjamin Franklin here, an ounce of prevention is worth a pound of cure. So I think we've all heard that before. We all have a general sense of what it means. What I would like to do is see how we might be able to translate this to heart disease and heart disease prevention. So before jumping into that, I would like to actually just take a step back and define health. So what is health? We all hear about it, we all talk about it, but I thought this was a really succinct and powerful definition from the World Health Organization, which is a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So I want to emphasize not merely the absence of disease, because this is where I think health and wellness and prevention really takes its meaning. We all have this sense, and myself included, we all have this sense that health is just the absence of disease, meaning if we're not acutely or chronically dealing with some illness or some symptom, then we must be healthy. And that's actually not correct. That's not the proper definition of health according to the World Health Organization. And I like how they included not just physical health in terms of symptoms and ailments, but mental health, which is so incredibly important and underappreciated, as well as social well-being, just being connected to your community, having a sense of purpose and meaning in your life. And all of these combine together, I think, to truly create health. And it's not just the symptoms and aches in our bones and things like that. So let me take that and move on to this concept of lifespan versus health span. I think we all are quite familiar with the concept of lifespan. And that is simply, sorry, if I could, is there a way to minimize the pictures? Just, there we go. Can you still hear me?
We can.
Okay, great. Just it's not covering up some of the slide. So I think we're all familiar with the concept of lifespan, which is basically the time from our birth to the time of our death. But another interesting part of that is chronic disease and disability. Life is precious, and unfortunately, death is a part of life. And at some point, we all are going to fall ill with certain chronic diseases and disabilities. And that is just the cycle of life. I think the key, however, is to, in a sense, not let that chronic disease and disability occupy a large part of your lifespan. So in essence, what we want to do is we want to compress this period of morbidity. And this is in fact referred to as the compression of morbidity, which is intervening at an early stage of disease, engaging in a variety of health promotion behaviors, all with the point of compressing this period of chronic disease and disability, which is inevitable for all of us. But ideally, this would encompass, if you will, the last few years or whatever of our life. And we would have a large portion of our life of health and wellness and the ability to do the things we want to do, to be engaged in all the things that we want to be engaged in, and really have the physical and mental ability to do that. So I think prevention and early detection is probably even more important of a role as it relates to the compression of morbidity than it is simply taking pills and having procedures to treat advanced disease. And I don't want to take away from the importance of those things because they're exceptionally important, as I'll get into in a minute. But they can only do so much. And there's so much scientific literature that's been validated time and again to show how impactful maintaining a healthy lifestyle and being actively involved in prevention and wellness. So with that, let's jump into heart disease. Let's start with, I guess, a historical perspective. So this is from the American Heart Association. They actually publish every year statistics on heart disease and stroke. And it is quite comprehensive. It's on average probably 250 pages of data. And it's updated every year with the latest numbers. And I always find it enjoyable when it first comes out in January to kind of look at trends. How are trends changing over time? Unfortunately, how is death from heart disease changing over time? But they also go way deep on this. They look at individual risk factors. How is smoking trending? Diabetes, high blood pressure. They look at diet. They also have many, many pages that look at the economics of healthcare as it relates to cardiovascular disease and how those things are changing over time. So it's really interesting. And personally, I find a little fun to look at this kind of data. But this looks at heart disease and in particular death attributable to heart disease dating back to 1900s. And as you can probably guess, over the next 60, 70 years, unfortunately, people dying from heart disease was on quite an upward trajectory. And this, I think, is multifactorial. Number one, we didn't have a good understanding really what heart disease was, what caused it. Smoking was quite rampant in the 20s, 30s, 40s, and on. Diets were exceptionally high in trans fat, which thankfully is now banned. So a lot goes into, just not knowing a lot about heart disease, what caused it. We didn't realize some of the lifestyle factors that contributed to it, but also we really had no tools in our tool belt to deal with patients that were ultimately diagnosed with heart disease. Aspirin wasn't really used until 40s and 50s. We really had nothing much to offer patients, unfortunately. And then about 1980, we hit a peak. Again, this is multifactorial. We started learning more about heart disease and the things that contributed to it. We started tackling smoking. We started treating high blood pressure and high cholesterol. There were more and more medications being developed to treat these risk factors, as well as to treat heart attacks and the sequelae of heart attacks. And then in the 90s and 2000, we started getting coronary stents and bypass surgery. So this also contributed to what, as you can see, is a nice, slow, but steady decline in the mortality. So a lot of things from a prevention standpoint, from a medication standpoint, from procedures, all basically in our arsenal to combat heart disease. And as you can see, we made tremendous strides in lowering the death rate. Unfortunately, starting about 2010, we are now seeing a rise again. More and more people are starting to die from heart disease. And it's quite troubling considering the amount of technology, the number of medications that are now widely available. So the question, of course, is why? Why, despite all these advancements in science and technology, our inherent knowledge about heart disease, are heart disease deaths starting to rise? So let's look at some of the favorable trends. Thankfully, smoking has been on a steady decline in all age groups. I think, trying to think of a good way to say this, but I think we figured out a way to battle the tobacco companies. And we've been very successful in terms of limiting marketing to children and things like that, the sales of tobacco. So that was a long, long struggle, but I think we're now finally starting to have a little bit of success in that regard. We have very good ways of managing high blood pressure and cholesterol, both pharmacologically as well as lifestyle. And this has contributed to, again, steady declines in the number of people with these risk factors, or if they have them, they're at least under good control. Now, what I think is contributing to the rise in death from heart disease are some other risk factors which were percolating right under the surface, unfortunately, for decades. So we're seeing really an explosion of obesity. We're seeing an explosion of diabetes. And not only that, pre-diabetes. So for those of you that are not familiar, you have normal blood sugar levels, you have diabetes, and then you have this gray area in between, which we refer to as pre-diabetes. We generally don't treat it with medications because it is exceptionally sensitive to lifestyle interventions. But if not addressed, it rapidly progresses to diabetes. There is something called metabolic syndrome, which is a combination of a variety of risk factors in combination, which includes diabetes, obesity, high blood pressure, cholesterol, and other measurements like waist circumference and things like that, which are basically measures, surrogate measures of obesity. So this is a syndrome which is also substantially increased. We have a very high prevalence in the country of physical inactivity. And this was pre-COVID. Approximately 30% of the population is deemed to be completely sedentary. I would argue that it's probably much worse over the past year and a half for understandable reasons, but it's still unfortunately a contributing factor. And then worsening dietary habits. This is something that I have a background in as it relates to nutrition. I'm very passionate about nutrition. And unfortunately, this has been exploding in terms of very, very poor diet quality for adults and in particular for children. In fact, I don't know how many of you maybe saw, I think there was a New York Times article about a week ago that came out that said about 65% of the foods that children are eating are considered highly processed, and a substantial portion of the adult diet contains highly processed, manipulated foods. And this is contributing to just overall poor dietary habits, and of course, from that, poor health. So how can we achieve health and not merely the absence of disease? So my approach to this is that health can be achieved two ways simultaneously: by working towards wellness, which I'll get into in a minute, and of course, early detection. And again, this all relates to heart disease. So unfortunately, for a 30-minute talk, I don't think I'll be able to spend much time on wellness. That could be a whole lecture in and of itself. But these are basically the pillars of wellness as I see them. This is what I think contributes to overall health and wellness and longevity. This is what I think all healthcare providers should be focusing on, in addition to just simply assessing for symptoms, testing, so on and so forth. And just to touch on it right here, physical activity is pretty self-explanatory. I think we all could benefit from a little more physical activity. We need to find ways to carve out a little bit of time in our days to do what we like to do. I think if you find something that you enjoy, something that you're willing to engage in, it doesn't have to be a sport, it doesn't have to be hitting the gym every day, it doesn't have to be, going and signing yourself up for a 10K race. I think you find something that you like to do, whether it be walking, yoga, really anything. And my recommendation is to start slow. Set a low bar for yourself. set goals that can be very easily achieved in order to boost your confidence and set you on the right path. Nutrition, again, a lot can be done in this realm. I think it's just a matter of, not to borrow the Subway ad, but to eat fresh, I think is the key. The more we can just focus on fruits and vegetables. I personally do not have an issue with, meats. I think just to choose kind of lean meats, perhaps more poultry, lots of fish, legumes, nuts, seeds, healthy oils, avocados, all that stuff. In essence, what I would say is for most people, a Mediterranean style diet would be the way to go. Certainly that can be tailored to an individual's, culture, what they like to eat, and so on and so forth. Psychological health, again, as I mentioned before, exceptionally important. Just recognizing things like anxiety, depression, other mental health issues, getting the appropriate, attention for those things, but also focusing on other aspects of psychological health, like having a sense of purpose in life, engaging in your community. These are all, I think, a part of psychological health, and they really have a spillover effect into other areas of wellness as it relates to physical activity, nutrition, et cetera. And then finally, sleep. I think this is, no pun intended, the sleeping giant. I would say if you ask 10 people if they have, do they have, good quality sleep, I would probably argue that 8 out of 10 do not. I think it's underappreciated how much difficulty people have with sleep. And this can tie into things like anxiety and depression. It can tie into medical illnesses such as sleep apnea and other sleep disorders. But it's really underappreciated. It should be something that all healthcare providers are asking their patients about, and helping them in whatever way possible. So these are kind of my 4 pillars of wellness. Again, it's a whole lecture unto itself, but I just wanted to share that part with you. So the other aspect of wellness is early detection. So what does that mean? I think it means basically trying to identify heart disease at such an early age that we can intervene in such a way as to either halt it if it's already present, ideally halt it at a very early stage, or ideally even prevent it. But when we think about early detection and prevention, we have to think about the risk factors. The risk factors that we know contribute to heart disease. And we have what I like to refer to as traditional and non-traditional risk factors. And these are all scientifically validated time and again. So we have things like age, gender, family history. We're all familiar with that. Unfortunately, there's nothing we can do about those things. Smoking is an obvious risk factor, which we can, intervene on. High blood pressure, high cholesterol, diabetes. But then there are also many non-traditional risk factors that are not commonly thought of as being risk factors for heart disease. But again, when you look at the cardiology literature, it's overwhelmingly clear that these things have a very strong correlation with heart disease. And that includes physical inactivity, poor diet, poor sleep quality. And there are many psychosocial factors, which again, are very strongly related to heart disease. Untreated depression, untreated anxiety, a lack of social support, not really having a good social support network, very strong risk factor. And more recently, things that I've been involved in and had the pleasure and privilege to work on some of these projects, studies identifying optimism versus pessimism. And I contributed to a study on this where we found that individuals who had, by an objective tool, basically a questionnaire, Individuals that were deemed to have a pessimistic outlook on life had a significantly increased risk for heart disease. And then something else, which I had a privilege of working on, is lack of purpose. So this was all ascertained again by a variety of questionnaires. And what we found was that individuals who felt that they had a true sense of purpose in their day, a sense of purpose in life in terms of their daily activities. And it did not have to be anything grand, but anything that they deemed was important and meaningful in their life and they engaged in on a regular basis. Those individuals had a significantly lower incidence of heart disease. So these are the things that we look at. These are the things that we should be looking at when we're thinking about early detection and early intervention. So when it comes to early detection, we have, I didn't really depict it here, but the iceberg. What we see hovering above the water are heart attacks, strokes, and death due to heart disease. When we look a little bit below the surface, we have patients who might be having symptoms. Maybe they have some tightness in the chest with activities, or some shortness of breath with activities that wasn't there before, or perhaps other subtle signs. This is kind of what we refer to as, I don't want to say asymptomatic, but it's not as dramatic. So people may not think that they're having perhaps early signs of heart disease and therefore may not get the attention that they need. And then when you go way below the surface, we have what's referred to as subclinical heart disease. And these are individuals that feel great, that have zero symptoms, that are doing everything that they want to do in life, no limitations. But when we do investigate a little further, when we scratch below the surface, we see in fact that heart disease is already actively underway. So that's where I believe we need to intervene so that we never reach a point where they're having symptoms and disability, and hopefully completely prevent these outcomes. So when we go to the doctor's office, it usually is because we're having signs and symptoms. The signs and symptoms usually result in traditional testing, stress testing, EKGs, blood work, things like that, looking for perhaps evidence of disease. But what can we do to, again, dig a little deeper? Can we identify any test or tool to identify disease at an earlier stage before, again, patients start actually having symptoms? And these would be things that we would be looking to target really during your annual wellness check, your annual physical with your healthcare provider. Hopefully things that can be eventually incorporated into, your annual physical. So again, if we can intervene at this early stage, this early detection of subclinical disease, then we can ideally have a significant impact on disease progression, have less morbidity, and as I mentioned before, ideally try to compress that morbidity and disability to the last year or so of our life. So is there a way to identify heart disease at an early, quote unquote, subclinical stage? So again, when we go to the doctor's office, these are things that are ideally done. We get our weight measured. Something called body mass index, or BMI, is often calculated. It's not routinely done, but something called waist circumference, where they simply just take a soft, almost like a tailor's measuring tool, and they just put it around your waist from your belly button all the way around and measure what's called waist circumference. It's not commonly done, but it in fact is a very, very powerful predictor of health and obesity, much more meaningful than either simply measuring weight or body mass index. Of course, we all get our blood pressure taken. Usually above age 35, 40, we start getting an EKG done, which is helpful, more for a baseline. We invariably will get blood work done to screen for diabetes, look for cholesterol abnormalities, and again, if present, intervene, and not necessarily in a pharmacologic way, but again, a lifestyle way, ideally, first. Ideally, the healthcare provider will ask you those questions that I mentioned about your lifestyle. What's your sleep like? What's your exercise activities? Tell me about your diet. Tell me about your social activities. Very simple things that just take a few minutes. And again, screening for sleep disorders. So there actually is a tool that I recommend, and many people in the field of cardiology recommend, to identify this group of people that I refer to as subclinical. So they're not having symptoms, but are they in fact starting to have plaque formation in the arteries? So this is just what we refer to as a cross-section of an artery in the heart. So you're looking right down the barrel of it, so to speak. So this is all normal, healthy artery. And then you can see in the yellow on cholesterol deposits. So this is why cholesterol obviously is such an important target, because it is a direct contributing factor to plaque formation. Yes, other things contribute, such as diabetes and high blood sugar, smoking, high blood pressure, inflammation. Heart disease is often felt to be an inflammatory condition, which is localized to the arteries of the heart. But nevertheless, these things contribute, such as cholesterol. So the yellow is cholesterol plaque. Excuse me. And if the cholesterol plaque sits around long enough, the body actually recognizes this as foreign. So what the body tries to do is it tries to protect the rest of your body, the rest of the artery, and the rest of your heart from this plaque. And it does so by laying down a shell of calcium on top of the cholesterol. And we refer to that as a cholesterol plaque. So on one hand, your body recognizes that this should not be here and is trying to protect itself by laying down this shell. And we can actually capitalize on that by doing a test which identifies the calcium shell that overlies the soft cholesterol plaque underneath. But if left unchecked, the cholesterol continues to deposit more and more. You get more calcium deposits, and eventually it reaches a point where majority of the artery is in fact blocked or partially blocked, and the blood flow is now being restricted. So as you can see here, even though there's a little bit of plaque here and a little bit more plaque here, there's actually no restriction to the flow of blood, and very minimal restriction to the flow of blood here, even though there's a large amount of plaque present. It's only at a very advanced stage does the blood flow start to get restricted. And it's this restriction in blood flow that now starts to cause symptoms. So when people come to the office complaining of chest pain, exertional shortness of breath that's out of proportion to what they usually do, it's quite possible, not always, but quite possible that they're already at a very advanced stage. So the key is, again, what can we do to identify patients here? So that we can identify when it's trivial and ideally prevent this progression. Now, in terms of testing, the traditional thing that is done in the doctor's office is a stress test. If you're starting to have symptoms, whether they're heart-related or not, at the time, we don't know. So we often refer patients for a stress test. A stress test, you should know, will only be abnormal if there's more than a 70% blockage in an artery. So people can go and get a stress test done, and that stress test can be normal. And that's very reassuring in a sense. But the only thing that you've really excluded is that there's no 70% blockage or more. There could still be significant plaque buildup that is going on that we may not be addressing as aggressively as we should. And the stress test, although very helpful at times, can be misleading. So the test that I and many people in cardiology recommend as it relates to early detection is called a coronary calcium scan. And just as the name implies, it's a scan to identify calcium deposits in the coronary artery. So again, basically a test looking for this, the white plaque. And if we see that there is in fact white calcium deposits present, then we know that there's this kind of plaque going on. They are synonymous. So this is a coronary calcium scan. What it is it's a CAT scan of your chest, and it's limited to just the region encompassing your heart. So unlike a traditional CAT scan, which might cover a large portion of your body, this is really isolated, if you will, just to the portion involving your heart. Because it is a CAT scan, there is radiation associated with the test, but it is actually quite low. A standard CAT scan of the chest can unfortunately give a moderate dose of radiation, but obviously if it's necessary to identify some serious underlying problem, then the benefit of the test outweighs the risk. A calcium scan is very different from a traditional CAT scan. There's no IV, there's no dye or contrast given, and the radiation exposure with a calcium scan is less than typically. It's less than a mammogram. And mammograms are done, as you know, quite routinely for screening for breast cancer. So this is a relatively easy, very fast test with minimal radiation exposure, again, often less than just a mammogram, and from which we can get a lot of very valuable information. So this is basically the heart. This is your spine here. So again, we're looking at this picture from the feet up. So this is the back, this is your spine, this is the ribs, this is your sternum or your breastbone, more ribs, and this is your heart. And the heart has three main arteries, one that goes down the front of the heart, one that wraps around the left side of the heart. This is actually the left side of the body. This is the right side of the body. And then an artery that goes down the right side of the heart. And each one of these three main branches, like a tree, has branches as well. So you essentially think of these three like a trunk, and off the trunk you have many branches. So this particular calcium scan has no evidence of plaque buildup in the three main arteries here. This is what it looks like. We are looking essentially for these white areas of calcium. And this is, again, synonymous with plaque, with the presence of plaque buildup. So we get what's called a calcium score, and that score gives us a number, but it's more qualitative. That number reflects the overall burden of plaque in the heart, and that score can range from 0, which is certainly the best, that represents no plaque seen. And it can go sometimes well into the thousands. So we basically, using computer software, we just identify all the areas of plaque, and the computer does a calculation and basically spits out a score, which is the calcium score. And then we can use that score to, again, more qualitatively say this person has trivial plaque, mild, moderate, and severe. And with that information, as well as all the other information we obtain during just a routine visit, can, identify interventions, ideally to just halt this process so that it doesn't progress or doesn't progress in any statistically significant way over time. And if someone has a score of 0, like this person, what can we do to try and keep that person with a score of 0? Again, primarily by lifestyle interventions. So again, this is what we're seeing here. This is another example, unfortunately, a lot more calcium. Again, more calcium. So again, the calcium scan quantifies the extent and severity of calcified plaque in the arteries of the heart. The coronary artery calcium score has been shown in literally thousands of scientific studies to correlate with future risk for a cardiovascular event. And what I mean by event, and this is a standard definition, having a heart attack, a stroke, needing a stent placed or bypass surgery or something like that. Any calcified plaque indicates that the process of heart disease is underway. Even a score of 5, let's say, it's very low, but even a score of 5 indicates that the process is underway and that we should be as aggressive as we can possibly be to intervene from a lifestyle and, if necessary, pharmacologic standpoint. Many people think that we should reserve aggressive interventions for aggressive disease, and that's true. But I think we also need to have aggressive interventions for very minimal disease with the goal of basically preventing the progression. So just some final thoughts. Advances in science and technology have allowed us to better treat individuals with advanced cardiovascular disease, prolonging and enhancing their quality of life. Unfortunately, we as a healthcare system, I think, have neglected health promotion and disease prevention. Again, that's a whole lecture unto itself. Traditional cardiovascular disease, which is referred to as coronary artery disease, believe it or not, is largely preventable. And they've done many, many studies looking at this, looking at people with genetic abnormalities, which, just as an example, there are individuals with genetic abnormalities who have cholesterol levels equivalent to a newborn. And those individuals never develop heart disease. So these are good models which tell us that this is largely preventable. Yes, there are other kinds of genetic abnormalities and predispositions that contribute, but for a substantial portion of people, heart disease and certainly the long-term sequelae can be prevented through early detection and lifestyle interventions. So a lot of information in a short amount of time. Hopefully I didn't go over time, but I would be happy to answer any questions.
Okay, you didn't go over time. That was terrific. And I do have a question for you, although I don't know if it's tongue in cheek. It says, with the advent of financial insecurity starting in 2008, as the stock market shrank considerably and the challenges to keep up with technological changes, I suspect this led to excessive mental stress. Isn't stress a major cause of increased heart disease?
Yes. Again, stress, that's a very good point. I think I left that off my slide as it relates to psychosocial factors. But yes, chronic stress is also a well-known, well-validated risk factor for heart disease. And it relates to many things. From a biologic standpoint, chronic stress leads to chronic elevations of adrenaline. Adrenaline is our fight or flight hormone that we all have. But when we're under chronic stress, that fight or flight hormone is chronically elevated. So our body is constantly being stimulated. And that's when it becomes pathologic or abnormal. Cortisol, which is a stress hormone, again, part of that fight or flight response, which we want. But when we're chronically stressed, we have chronic elevations of cortisol. Chronic elevations of cortisol lead to high blood pressure. They lead to high blood sugar levels and eventually diabetes. Chronic stress leads to obesity. But then there's a whole psychosocial aspect of chronic stress, which is when, and this is understandable, when we're stressed, we're less motivated to exercise. When we're stressed, we don't sleep well. When we're stressed, we tend to make poor dietary choices and engage in other health adverse behaviors like smoking and alcohol and things like that, alcohol in excess. So yes, very important, risk factor, and unfortunately, it's ever present in society.
True, it's true. Gloria asks, is my sister-in-law has an erotic aneurysm, is an aortic aneurysm. Is it genetic and how serious?
So that's a good question, and the answer is yes and no. An aortic aneurysm is basically an enlargement. Just to show you, so this is our heart, and this is actually the aorta. The aorta is the main artery that exits the heart and branches off and gives blood to the rest of our whole body. So the heart pumps and pushes all the blood into the aorta, and the aorta delivers it to the rest of our whole body. So a very important tissue, if you will. When the aorta becomes enlarged, we refer to that as an aneurysm, and it can become enlarged at any part in its course. The aorta actually courses from right below your, I don't know if you can see me, but right below your kind of larynx here. And it goes all the way down to about your belly button area. The aorta covers that whole area. And at any point in its course, it can become enlarged, and we refer to that as an aortic aneurysm. So there are, thankfully, very few genetic conditions which predispose to aortic aneurysm. And when it is genetic, or if we suspect it's genetic, screening of first-degree family members is generally indicated. But there are more commonly aortic aneurysms due to just traditional factors, probably most importantly being smoking and high blood pressure. Those would be the two most significant causes of aortic aneurysm. And it's a very serious condition. It needs to be very closely monitored. If it grows beyond a certain number, obviously it will essentially require surgical intervention.
All right, and what are some additional subtle signs of early heart disease?
So that's a good question. As I mentioned, I could pull this up here. So with these three stages of heart disease, I would expect the individual to be completely asymptomatic, meaning no symptoms at all. They feel great. They have no limitations in terms of their day-to-day activities. And that's why heart disease can be so devastating, is that one day someone feels great, the next day they have a heart attack, is because people typically don't have symptoms until it's in this range. And the symptoms can start out very subtle. Yes, you can, the more dramatic presentation would certainly be a sudden heart attack where there's sudden chest pain, shortness of breath, cold sweat, nausea, things like that. More subtle signs would be perhaps a little general tightness, pressure, heaviness in the chest, particularly with activities. Light exercise activities, going up flights of stairs, discomfort perhaps with things that didn't previously make you feel that way. Also shortness of breath, particularly shortness of breath with exertion, doing things that didn't previously make you short of breath. Those would certainly be more subtle symptoms that would certainly warrant investigation. But again, this is why early detection is so important, is because people often don't have symptoms until it's already very advanced.
Okay. Going back to the, let's see if I get back to the question. Is calcium plaque levels related to particular lifestyle or nutrition?
That's a good question. No. So the calcium in our diet, dairy and other vegetables and whatnot, as well as calcium supplements that many of us take, has no impact whatsoever on the calcium deposits in the arteries of the heart. We obviously need calcium in our diet for our bones and bone growth and bone stability and bone health. But thankfully, there's no relationship whatsoever. So it's very important to have calcium in your diet and to take supplements if you've been told to take supplements.
All right. And is there a difference in prevalence of heart disease between men and women?
That's a good question. Typically, before menopause, there is a much higher risk of heart disease in men. Estrogen is very protective in its natural form. However, once menopause hits and the estrogen levels naturally fall, the risk for women now becomes equivalent to men.
Okay. My wife has a question for you. Fire away.
I've been told that once you have the calcium test done, that you never have to have it done again. Why is that? Does it not change?
Again, very good question. My approach to this is if you have a calcium scan done and the score is 0, that's obviously great news. Basically keep working on prevention. It's not to say that I'm good, I don't need to watch myself or be mindful. I'm just going to go on my merry way. No, it's obviously good that the score is 0, but let's still focus on healthy lifestyle so that we can keep it 0. And to that point, what I will recommend to patients is when someone has a score of 0, the current recommendation actually, if you look at the cardiology guidelines, is that in about 4 to 5 years, the calcium scan should be repeated. If someone is a diabetic, that recommendation drops to about 3 to 4 years because diabetes can accelerate heart disease. So certainly if it's 0, it should be repeated. If the score is low, under 100, let's say, and from my standpoint, under 50, I personally would still repeat it in 3 to 4 years. The reason for that is it's a very good metric to see if your interventions are working. So if we identify that there is some plaque there and you have, for example, a score of 10, and we tackle all the relevant risk factors, we're making lifestyle changes, we're doing everything that we think we should be doing, and we repeat the calcium score in 3 to 4 years, and that score of 10 is now 100. We now have an objective tool to say we're not doing a good enough job, that we need to lower, for example, the blood pressure a little more. We need to drive those cholesterol numbers even lower. Let's see what else in our lifestyle we can tweak, a little bit more. So I find it particularly helpful to repeat it when the score is low, to use that as a gauge of how good of a job we're doing. But But to a certain extent, your question is also correct. If someone has a score of 100, 400, those individuals have a pretty significant amount of plaque buildup already. And the ability, I guess, at those higher numbers to assess for progression is not as useful. For example, if someone has a score of 400, that's already considered a severe burden of plaque. And, we want to throw, the whole kitchen sink at that person. We're going to do whatever we possibly can to, get the cholesterol super, super low, which again is a whole nother lecture I'd be happy to discuss. Get the cholesterol super low, get the blood pressure numbers down very, very low. Be as aggressive we possibly can, such that repeating the calcium scan is probably not going to be very helpful.
Is calcified plaque a cause of a lot of, back that up. Calcified plaque is the cause of what percentage of heart attacks?
So the short answer is I don't know the answer to that.
Okay.
When someone has a heart attack, we often think that it's these individuals, if you can see the slide. It's these individuals that have a 90%, 95% blockage. And then all of a sudden it becomes 100. That's actually not the case. These people, again, certainly have symptoms and certainly need interventions. Believe it or not, most people who are suffering heart attacks are in this category or this category. And the reason for that is they already have a substantial amount of cholesterol plaque present. And we refer to that cholesterol plaque as soft plaque. And another term that we use in cardiology is vulnerable plaque. The reason for that is the body perhaps has not had enough of an opportunity to lay down a protective shell. And that protective shell of calcium actually often prevents the plaque from rupturing. And what I mean by that is what can happen for a variety of reasons is the thin tissue that separates the inner lining of the artery from the cholesterol ruptures. And you have cholesterol and inflammatory cells, in a sense, spilling over into the opening, the hole of the lumen, we refer to it. And that rupture of the plaque triggers an immediate response from the body. The body immediately recognizes that rupture as foreign. And what happens is it starts laying down very acutely in a matter of seconds, inflammatory cells and blood clotting cells. So what happens is you go from, this might be 40%, 30% right here, plaque buildup. And when it ruptures, it goes from 30% to 100% in a matter of a minute. And it's that sudden change from 30% to 100% that causes the heart attack. So it's these individuals that we really worry about. These individuals, again, typically have symptoms, often not a heart attack, but symptoms. And they go to the doctor and they get checked and we intervene. So these are often addressed and treated before they, can cause a problem. It's these individuals that we worry about where there's a lot of cholesterol plaque and perhaps not a lot of calcium. So I guess that answers your question. That
right.
That's the long-winded answer.
All right. And my chemist friend Bob says, what's the chemical compound of calcium plaque? Is it carbonate, phosphate, or what?
Oh, that's an excellent question. I believe it's calcium phosphate.
Bob hit it again. All right. Well, Good job. You know, I really have to say, as we come to a close this evening, that the idea of wellness is perhaps not articulated often enough. We are more reactive than proactive.
Correct.
And I think that keeping the presentation you made does do a good job in reorienting my head at least. I hope it did that for others as well. I have one final question for you as a quickie.
Sure.
Do insurance companies pay for the screening of a calcium test?
Good question. Many
Yes, I
insurance.
think yes is the answer. I had it done.
I'm sorry.
I said that yes is the answer. I had it done.
Okay. I believe many insurance companies do reimburse. My experience with this is that they often will not cover it right off the bat. You have to submit a claim to the insurance company, and then it's often reimbursed.
Okay.
Now, what I would say is shop around. If this is a test that you're interested in getting, and your doctor recommends getting the test done, ask them what the cost is. This is a CAT scan. It's a very standardized test. It's almost fully automated. So it's very reproducible, and therefore can be done really at any radiology, institution that does CAT scanning. Unfortunately, there is tremendous variability in what places charge. If you go to Manhattan, you can get this test often for $99, $75 out of pocket. I don't know why. I don't know how they justify doing it. There are radiology centers which charge $250, $199, a whole spectrum of costs. And what I would say is shop around. If your doctor is recommending a particular radiology place, call them and just say, I was recommended to get this test. What's the cost? And shop around a little bit, because if you spend maybe 30 minutes calling a few places, I bet you'll find a place that offers it for $99 or even less. And again, it's a very standardized test. So a $99 test is just as good as a $250 test.
Like
and
that.
The only thing that the doctor needs is the report. So just get a copy of the report and bring it to them.
Well, I encourage everyone to do that. It's worthwhile. It's 15 minutes. It's painless. So I think it's an asset for people to do. David Weiss wants to know, is this the same as a CA and blood test?
What do you mean?
Calcium.
Calcium.
Oh, calcium in the blood. No, again, completely different. So the calcium that's often measured in a standard blood panel is very different than the calcium in the arteries, and one has nothing to do with the other.
Okay, that makes sense to me.
Yeah.
Well, you guys were terrific. Both you and Heather did a tremendous job. I'm really delighted they're going to be able to, we've recorded this program. Great. For people to go back and look at it, those that have missed it, and I'll encourage them to do so. And you really have added a highlight to our season as we come to kind of a close before the New Year's.
Yes.
We'll take a break during the holiday season before we come back to other fine programming, and you've really done a great job. And I know that everyone that was with us tonight really does appreciate that. Any last questions? Chris and Evan, I can see you sitting there with your lips, I know you're good. Yeah, you've been to your cardiologist. I see you're all right. You're in good shape. I like that. All right. Well, Randy, fantastic job. Thank you so much for taking the time out of your busy schedule in life. And Heather, we want to say thank you. And we want to wish you Shana Tova, as that's right upon us. And really do appreciate your time and effort in making this special program. And you did a great job with the graphics as well. in your-
Thank you. Thank you. I appreciate, we both very much appreciate the invitation, and it was a lot of fun, and Shana Tova to everybody, and look forward to seeing everyone soon.
All right. Have a great night
Thank
and
you.
terrific job. Thanks again.
Thank you. Have a good night.
Okay. Bye-bye.
Bye-bye.